Dr. Mahapatro, please.
First of all, I am thankful to the organizing committee and particularly to Dr. Anil Kumar for giving me this opportunity. Respected persons in dais, seniors and friends, here I am going to discuss about a puzzled case. I really wanted to see the perspective how others are taking about this case. This is a gentleman, 44 years old male, presented with on 1st of March with history of low-grade prolonged fever for 1.5 months duration, dry cough for 1 month, and he was having breathlessness, NOHA class 2 to 3 for 20 days duration. On clinical examination, this patient did not have any abnormality. Hematological examination did not reveal any abnormality except ESR of 60 mm in the first hour. Biochemical investigations were normal. His Montauk's examination showed 24 mm swelling with indurations. His viral serology were negative. Retrospectively, I have done VDRL and antinuclear antibody test for this patient, which showed negative. His ECG was showing sinus tachycardia. X-ray, there was moderate cardiomegaly with CT ratio of 65%, and echo heart revealed moderate pericardial effusion 15 to 17 mm posterior and lateral to LV and 12 to 13 mm anteriorly. Basing on these, I have done a pericardial fluid analysis on him. His pericardial fluid analysis showed it's a exudative fluid with protein of 5 g%. It was lymphocytic predominant fluid with lymphocyte of 80% in a total count of 3,700. His ADA revealed 30 units per liter. Based on these findings, I started the patient on antituberculosis treatment on 6th of March 2011. This patient did not come for follow-up. After 2.5 months, the patient presented again on 1st June with features of congestive cardiac failure. He was having pedal edema, breathlessness, raised JVP and tender hepatomegaly. Now, his ECG revealed there is sinus tachycardia with poor progression of R wave up to V4, as we all see. This stage, his echo heart revealed there was regional all motion abnormality in LAD territory, moderate LV systolic dysfunction, moderate degree of mitral regurg, moderate degree of tricuspid regurgitation with pulmonary arterial hypertension, and there was 12 to 13 mm pericardial effusion in posterolateral to LV and 8 to 10 mm anteriorly. Now he was admitted and managed for congestive cardiac failure. At this point, I thought of, as he is having regional motion abnormality, so planned for a catheterization study, both right heart, left heart pressures, and as well as coronary angiography. His catheterization data showed there is a raised LV and diastolic pressure of 25 mm mercury. There is evidence of pulmonary arterial hypertension in view of raised RV systolic pressure and PS systolic pressures, and mean right atrial pressure was raised. There was no saturation abnormalities. It was matching. This is his coronary angiogram. This is left coronary shoot in yellow caudal view. So there is a large aneurysm in the osteoproximal LAD, as well as there is a critical lesion in the ostial circumflex artery. Again, this is the epicranial view where the same aneurysm is shown, and as we see carefully, there is a TME1 grade, TME1 flow in the distal left anterior descending artery. Again, the same injection showing the large aneurysm well delineated in this view with the ostial circumflex lesion. This is the epicaudal view of left shoot. His right coronary injection did not show much disease with minimal distal disease. Now, let us discuss what is the diagnosis of this case, who has misled and misdiagnosed earlier, and what should be the line of management at this juncture. To me, the diagnosis is like it's a critical coronary artery disease case with large osteoproximal aneurysm of the left anterior descending artery with a critical lesion in the ostial circumflex and moderate degree of pulmonary arterial hypertension. There was no features of constrictive pericarditis. So, how and what will be the management for this case? As this patient was having a large aneurysm and having multivessel disease like both LAD and ostial circumflex, I thought of surgical management for this case. After handing over the case to the surgeon, these are the pictures, like this is the aneurysm showing clot inside the aneurysmal cavity. This picture is showing the aneurysm has been repaired by unroofing the aneurysm, and there is a cannula passing from the distal LAD into the aneurysmal cavity. This is the final repaired aneurysm with grafting of the coronary artery. This patient undergone a coronary artery aneurysm repair along with bypass grafting to LAD by left intracoronary artery and to the major marginal by venous graft. These are the clots removed from the aneurysm of this patient. We have sent this specimen for histopathological examination. Histopathology showed there is a dilated vessel wall with endothelial lining and a thrombus attached to the vessel wall. This is the histology of the thrombus showing altered layers of dark and pale areas consisting of RBCs, WCs and platelets. There was no inflammatory cells, there was no bacterial colonies, there was no subintimal plaque or any calcifications. Basing on this, now to summarize the case, this patient initially misdiagnosed or misled as a case of pericardial disease with tubercular pericardial effusion, but ultimately turned out to be a case of large coronary aneurysm measuring 60 to 40 millimeter and filled with clots extending posteriorly into the transverse sinus. This patient was managed with surgical management in view of large aneurysm as well as multivessel coronary artery involvement. So he underwent a coronary artery bypass grafting with lima to LAD and venous graft to circumflexor. To conclude, cases of coronary aneurysm can have varied presentation. Once they are symptomatic, mostly they present as case of myocardial ischemia or myocardial infarction, and for the most part, when it is due to atherosclerosis, presence of aneurysm does not change the management decision, treatment decision, and the prognosis, if early intervened, is good. After all, we treat, he only cures. Thank you all for kind attention.
So what is your final diagnosis?
This is a case of critical coronary artery disease with large aneurysm of the LAD as well as ostial circumflex lesion, most probably due to atherosclerosis.
And the fluid in the pericardial cavity?
Actually, the cause and effect I am not very sure and not known. Maybe this is a contained leak into the pericardial sac from the aneurysmal cavity that has given pericardial effusion in this case.
No, but you didn't find any blood, you found lymphocytes, you find ADA at a little higher level. So what would you do? You will continue ATT or you will stop
no,
ATT?
No sir, we stopped the ATT and patient came for follow-up over 1.5 months. He is doing well. We have stopped ATT.
How long did you give ATT?
Last 2.5 months, 3 months he has taken.
Did you consider aorta arteritis type 5?
Because other aortic abnormality, any ostial subclavian disease, carotid bruit, no clinical examination, any suggestive finding we got for thinking about a aorta arteritis in this case.
Any suggestions or questions from the audience? It's a very interesting case. No correlation.
Both are independent because patient had fever for 1 month, which is not due to aneurysm. Patient has a MAN2 positivity, ESR is 60, MAN2 is strongly positive, 24 millimeter. And the other thing is patient also ADA is more and pericardial fluid is 24. This must be incidental. Both are independent, but this they detected only after they saw the CCF. But this patient requires continuation of anti-tuberculosis drugs. Otherwise, they may come back again with the same problem.
I think this point is
I
very
agree,
valid.
sir. But the thing is now then we have to contemplate for 2 diseases. If we think of...
It should be 2 diseases because you didn't diagnose, because the aneurysm cannot develop overnight. If the aneurysm leaks, then the whole thing is different because he may have a contained leak of aneurysm in the pericardial cavity producing so much effusion. If you have a moderate effusion because of leak, the patient would have died with tamponade.
Yes, sir.
So
yes,
this
sir.
is a different situation because you have hemodynamics wise, if you have a moderate pericardial effusion because of leak, he cannot survive.
Only Capdata did not show any constrictive pericarditis evidence over 3 months.
No, constrictive, you have treated with anti-tubercular drugs, he responded. You should feel happy that he responded and you should continue anti-tubercular drugs.
I fully agree, sir.
Do you consider Kawasaki's disease?
Kawasaki,
yes.
this man is 42 years old, and other point is for Kawasaki disease, the biopsy would have revealed as a onion peel thickened arteries with inflammatory cells. Those things were not there, and the patient has grown up to 44 years of age, so we could not think that was.
Second time patient came back after 3 months and he has continued 3 months of ATT. With that, ESR did not come down.
No,
With
sir,
that,
ESR was
diffusion did not come down. Then what is the rationality of continuing ATT after 3 months?
That's it. We stopped it, but anyway, patient is on follow-up. At present, with 1.5 months of therapy, he is doing good after his bypass and aneurysm repair.
No, but the recurrence may come because ESR is not the only thing. Patients, he responded, fever has subsided.
Yes.
But this might be an incidental thing. But again, the atherosclerosis as a cause of aneurysm, you are not finding anything in otherwise.
Atherosclerosis only, mostly.
What was the surgeon's comment on the pericardium? Because they had opened the heart and they had seen.
Sir,
There was always a
this
role
was
for
a-
pericardial biopsy also here.
This
Did
was
they do
a
it?
true aneurysm.
No,
Both
I'm not talking
biopsy-wise
about
as well
the
as,
coronary.
surgeon's finding wise, and there was adherence to the aneurysmal wall.
No, no.
Pericardium was adherent to the aneurysm wall. As the aneurysm was extending up to the transverse sinus of pericardium and posteriorly to the MPA, there was adherence of pericardium, but we have not taken pericardial biopsy.
That would have solved some.
I think we should always keep possibility of two diseases.
Yes, sir.
I tell you, we had a very interesting case. A young man came with myocardial infarction, had pericardial effusion. We tapped the pericardial effusion, it was malignant, and we found that the male person had a CA breast small. So in this case also, I think there is a strong possibility that there were two pathologies, and ATT should be continued. That's my view.
Thank you, sir.
Thank you
you.
for a very interesting case. Thank you.